everyone, welcome back to my channel. So early morning Sunday one shot is ready. So now let's move for the history taking of psychiatry.
Well, let's begin. Just the mic. Yeah, I'm live. So let's see. So today we are going to do with very important. Okay. Okay. Got it. The psychiatry history and examination. So this is a very important aspect. Okay. 1 minute. I'm coming Oh my god, I have been speaking from a while without switching on my mic on. But anyhow, now I will be speaking properly. Okay. See, psychiatric disorders. These are like it is a very skillful interview or history taking, because here the psychiatric patient, what he's telling is important to us, because based on his telling, based on his or her you know orientation, we can get to know whether the patient is really suffering from psychiatric illness, or the informant or the person with the patient. We need to know whether the fault is in the patient or with the family or whatever colleague, whatever person is there with the patient. So we need to note down the history, what the patient is saying. We need to note down what the patient is saying. So okay, what the patient is saying plus what the informant is saying. Informant is a person. So informant is a person actually who will be coming with the patient and informing that this is the thing, they are behaving like this. Okay. So the patient which is there who is mentally ill, we have to think whether the informant is correct or whether the patient is correct. If the informant is the correct, then we have to conclude that the patient might be having some psychiatric disorder. But if the informant is wrong, then the patient is maybe because of the informant, because of the family, the patient has been in this situation. Okay, so whatever the informant is saying and whatever the patient is saying, we have to note down the details separately, because sometimes what happens, because of the property or because of something, the patient is uh, giving some medications so that the patient becomes ill. Okay, so sometimes because of the property, or sometimes the disorder might be in the informant. The disorder might be in the informant, but the patient is brought to the hospital. So like that, we have to, note down whatever they are saying separately. So a psychiatric interview is different from normal medical interview, because the presence of the disturbances in thinking, behavior, emotions can interfere with the communication. Suppose you get a patient of depression, okay? Depressive patients, they don't speak much, they will be silent, okay? So asking the questions, but the patient is not willing to answer anything. So this is a psychiatric illness. You have some communication problem, you cannot take the history properly. So sometimes schizophrenia patients, they have lack of insight. They don't know what is real, what is unreal, poor judgment skills. So what happened at the time they have hallucinations and all, schizophrenia patients, they can attack you also, the physician also. So they have to be careful. During the interview session, the patient should be put at ease and an empathetic relationship should be established. An empathetic relationship should be established and patient should be calm and ease. Okay. Psychiatric assessment, history taking, interview, and mental status examination need not always be conducted separately. Okay, not separately. At a time, you have to take everything. Though they must be recording individually during assessment, the interviewer should observe any anomalies in verbal and non-verbal communication and make note of them. So his or her, the patient gestures, how they're sitting, how they're talking, the way they're behaving with you is also important, other than what they're speaking. How they are coming. Okay. It is helpful to record patient's response um, verbatim rather than only naming the signs. For example, rather than just writing delusions of persecution, it is better to record in addition, my neighbor is trying to poison me. It is best done in patient's own spoken language whenever possible. After it. For example, in the cases of delusions or persecution, the psychiatric person is feeling something unusual, right? The neighbor is trying to poison him or her patient. So you have to write in their own words, not that patient having a delusion. No, but this said you have to write that in their own words. Okay, not the patient's own words. So it is useful to ask open-ended and non-directive questions. For example, how are you feeling today? Rather than asking direct leading questions, for example, are you feeling sad at present? You should not ask like that. How are you feeling today? But in looking at the patient, oh, you're feeling sad. No. That's how are you feeling? Arguably, the most important interviewing skill is listening and demonstrating that you are interested in listening and attending to the patient. It is important to remember that listening is an active and not a passive process. Listening, just you're looking at your phone and listening to the patient. No, it doesn't mean you have to actively participate. Okay, like this, this happened. Confidentiality must always be observed. Okay. However, in cases of suicidal, homicidal abuse, and child abuse, an exception may have to be made. You have to tell to the patient. Okay, the patient parents or whoever is that this person is in a suicidal risk or homicidal risk. So we saw a patient in our psychiatric posting. So the patient was having doubt on her husband that he would marry again. So that the patient was getting depressed. She was having a tumor in her head, and because of the tumor, she was very stressed because of some usual fights between the husband and the wife. What were happening is they were fighting a lot, and she was getting suicidal thoughts. And then she was kept in psychiatric ward. Psychiatric ward is very closed. You don't have the windows are also closed with the welding steel rods. Okay, it's very difficult to escape from there. And what can you stay at the outside of the door? So it's very difficult. So a comprehensive psychiatric interview requires more than one session. The psychiatric assessment can be discussed under the following heading: identification of the data. Okay, so now let's talk about the actual interview. Identification data I have to take first. So identification data. It is best to start the interview by obtaining some identification data, which may include what is the name, okay, age, sex, marital status, education, occupation, income, office address, residential address, religion, socioeconomic, socioeconomic as appropriate according to the setting. It is useful to record the source of referral to the patient. In medical legal in cases, in addition to identification, marks should also be recorded. Two identification marks should be recorded if it is a medical legal case. So residential and office address, religion, socioeconomic background as appropriate according to the setting. Informant. Since sometimes the history provided by the patient may be incomplete due to factors such as absent insight or uncooperativeness, it is important to take the history from patients, relatives, or friends who act as informants. The patient relatives and friends they act as informants and sources of collateral information. It is important to take the patient's consent before taking this collateral history unless the patient does not have capacity to consent. The informant's identification data should be recorded along with the relationship to the patient, whether they stay with the patient or not. Because the duration of the stay together. The patient, if the informant is not staying with the patient, how can he know or he or she know about the patient? So they cannot be reliable at that moment. So you should know the duration of the stay together. Finally, a comment should be made regarding the reliability of the information provided. The reliability of information provided by the informant should be assessed on the following parameters: relationship with the patient, intellectual and observational ability, familiarity with the patient and length of stay with the patient, and degree of concern regarding the patient, the source of referral such as letter from patient general practitioner or letter of referral from referring physician surgeon in case of realization psychiatric referral. So often provides valuable information regarding the patient's condition. Presenting chief complaint. The presenting complaints and or reason for consultation should be recorded. So presenting complaints and or reason for consultation should be recorded. Both the patient's and informant's version should be recorded if relevant. If the patient has no complaints due to absent inside this fact should not also be noted. So why the patient came to the psychiatric clinic or OPD or hospital? You should ask the reason. It is important to use patient's own words and to note the duration of each presenting update. Some of the additional points which should be noted include onset of present illness or symptom, duration, course of symptoms or illness, predisposing factors, precipitating factors, and perpetuating factor. Use patient's own words and note the duration of each presenting update. Some of the additional points which should be noted include onset of present illness or symptom. कब से हुआ? ठीक है, duration of present illness. क्या duration था? Course of symptoms or illness, predisposing factors, precipitating factors, perpetuating factor. History of present illness. When the patient was last well or asymptomatic should be clearly noted. This provides useful information about the onset as well as duration of illness. Establishing the time of onset is really important as it provides clarity about the duration of illness and the symptoms of the illness in the earliest time. Oh my god, wait a second. Okay, so history of present illness, how you have to take. So you have to know the onset of each illness or each chief complaint what the patient is providing, duration. So the time you will come to know. Earliest time at which change was noticed, the onset until the present time should be narrated chronologically in a coherent manner. तो पहले क्या हुआ, उसके बाद क्या हुआ, उसके बाद क्या हुआ, ऐसे ऑर्डर में. ठीक है, सबसे पहले क्या हुआ था. The presenting chief complaints should be expanded. Chief complaint should be chief then is not the word. The presenting chief complaint should be expanded as usual what we do in the history. So in particular, any disturbances in physiological functions such as sleep, appetite and sexual functioning should be inquired. Is there any difference in the sleep pattern or appetite or sexual functioning should be inquired. One should always inquire about the presence of suicidal ideation, ideas of self-harm, idea of harm to others, okay, with details about any possible intent and or plans. It is also essential to consider. You should know the plans. Especially saying you that I want to kill myself, I want to kill my neighbor. So what you should ask, what are the plans? How will you kill? What are the plans? How will you kill? So if the patient says, I will jump from the floor, then you should not stay in the building. Okay. Or if the patient is saying, I will poison my neighbor, so you should keep the patient away from the neighbor and the poison. Okay. So it is also essential to consider any record, any important negative history, such as history of alcohol, drug use, or psychosis. Okay. A life chart provides a valuable display of the course of illness, episodic sequences, polarity, severity, frequency, relationship to stressor, response to treatment. What is the past psychiatry medical history? See, any history of any past psychiatric illness should be obtained. Any past history of having received any psychotropic medication, alcohol and drug abuse or dependence on psychiatric hospitalization should be inquired. A patient history of any serious, a past history of any serious medical or neurological illness, surgical procedure, accident or hospitalization should be obtained. The nature of treatment received and allergies, if any, should be ascertained. A past history of relevant etiology causes such as head injury, convulsions, unconsciousness, diabetes, mellitus, hypertension, coronary artery disease, active intermittent porphyria, syphilis, and HIV positivity or AIDS should be explored. Past history of whatever disease they were having, physical abuse is there at the age of, child is having any physical abuse at the age of 7 to 13, below average at 16 to 17. Auditory hallucinations, persecutory delusions, withdrawn, um, see if there is any weight loss, no sight, insight of persecutory delusions. Amphetamine use, regular cannabis use, they cause these auditory hallucinations, persecutory delusion. An example of lifestyle. Mellitus, hypertension, coronary artery disease, active intermittent porphyria, syphilis, HIV positivity, or AIDS should be explored. Treatment history. Any treatment received in present or previous episodes should be asked along with history of treatment adherence, response to treatment received, any adverse effect experienced or any drug allergies which should be prominently noted in medical records. Family history. The family history usually includes the family of origin, that is the patient's siblings, parents, and grandparents, uncles, etc. The family of the family of yeah, the family of procreation, that is the patient for children and grandchildren, conventionally recorded under the heading of personal history. The family of procreation, that is the patient's for children, grandchildren, conventionally recorded under the history of personal history. Family history is usually recorded under the following headings: family structure, drawing of a family tree, pedigree chart. Okay, can help in recording of relevant information in very little space which is easily readable. An example of a typical family tree is given. So it should be noted whether the family is a nuclear one or extended family or joint family. Any consanguineous relationship should be noted. The age and cause of death, if any of family members should be asked. Family history of similar or other psychiatric illnesses, major medical illnesses, alcohol or drug dependence and suicide. Any suicidal attempts should be recorded. Current social situation, home circumstances, per capita income, socioeconomic status, leader of the family, nominal as well as functional, and current attitudes of family members towards the patient's illness should be noted. The communication patterns in the family range of affectivity, cultural and religious values, and social support system should be inquired about where relevant. This is the pedigree chart. Yeah. So here a patient is 60 years, retired and having hypertension. Hypertension. The primary hypertension, primarily educated. Okay. So here he 40 years myocardial infarction, 15 years back, housewife died. Okay. Housewife is not there. No more. 35 years married, advocate LLB, one suicide attempt, 5 years back, bipolar disorder. His children. 30 years married, housewife BA. 20 years married engineer BA. 24 years typist BA. 27 years journalist MA. 5 years nursery, 2 years. So these are the personal ones. Okay, so this is what Okay, this is psychiatric disorder. ठीक है ठीक है, एक्चुअल ये है बता हो रहा है, ठीक है. A typical family and common pedigree symbol. This is that अगर क्रॉस डाल दिया मतलब they are not there. This is present patient. Psychiatric disorder. Psychiatric disorder में ऐसे बोल रहा है female ये अच्छा लो. Present family of the patient. Special emotional attachment. Indicates consanguinity. Miscarriage female or male or sex unknown. Okay. Miscarriage or monozygous twins. Dizygous twins, unmarried. Child adopted out of family. Child adopted into the family. Separation or divorce. So when he was well, he was saying that ये उनके actual family है actually. This is the actual family. This is the actual family. But he is telling during the psychiatric setting, he is saying that these are the conditions. The child is 24 years, he is a typist, BA, 27 years, journalist, MSR. Okay, she is the daughter. And she have 5 years university child and 2 years good. So the 60 years patient, he has no wife, but his wife has died 15 years back, and he's having a girl child, and she's 24 years, be a typist, and he's very emotionally connected, attached, and the 5 years boy is there, and 2 years girl is there. He's married to, she is married to 27-year-old, but the daughter is married to a 27-year journalist, and personal and social history. So in younger patients, it is often possible to give more attention to details regarding earlier personal history. In older patients, it is sometimes harder to get detailed account of the early childhood history. Parents and older siblings, if alive, can often provide much additional information regarding the past personal history. So all questions need to be asked from all patients and personal history, much like rest of the history taking should be individualized to each patient. Personal history can be recorded under the following heading. Perinatal history. Difficulties in pregnancy. Like pregnancy से start करना है आपको कोई भी history psychiatry में pregnancy पर. ठीक है. Particularly in the first 3 months of gestation, such as any febrile illness, कुछ बुखार आया था, any fever or medications you have taken, mother has taken, or drugs or alcohol use, abdominal trauma, and physical or psychiatric illness should be asked. Other relevant questions may include whether the patient was a wanted or unwanted child, date of birth, the patient having wanted or unwanted child, date of birth, whether delivery was normal, any instrumentation delivery was done, they're born, hospital or home, any perinatal complications, cyanosis, convulsions, jaundice, APGAR, APGAR score if available. Birth cry, immediate or delayed, any birth defect, any prematurity, you have to ask for this. What is childhood history? Whether the patient was brought up by the mother or someone else, breastfeeding, weaning, any history of suggestive maternal deprivation should be asked. The age of passing each important developmental milestone should be noted. The age and ease of toilet training should be asked. The occurrence of neurotic traits should be noted. This includes stuttering, stammering, tic enuresis, ecopsis, night terrors, thumb sucking, nail biting, head banging, body rocking, morbid fears or phobias or somnambulism, okay, temper tantrums, and food fights. What are temper tantrums? You see, mostly I have seen the children. If they want something, they will cry. They will, they will cry a lot, irritate you a lot. Hurt themselves by falling down or beating them by, banging their head on the wall. This is called temper tantrums. Yes? Educational history. The age of beginning and finishing formal education, academic achievements, and relationships with peers and teachers should be asked. I make a separate video on the behavior of kids. Okay. Any school phobia, non-attendance, truancy, any learning difficulties, reasons for termination of studies, it occurs prematurely should be noted. Play history. The questions to be asked include what games were played at what stage, at whom and where. Relationship with the peers, particularly the opposite sex, and should be recorded. The evaluation of play history is obvious, more important in a younger patient. Puberty, the age at menarche, the reactions to menarche in females, the age of appearance, secondary sexual characteristics, both females and males, natural nocturnal emission in males, masturbation, any anxiety related to changes in puberty should be asked. Menstrual obstetric history, the regularity and duration of menses, the length of each cycle, any abnormality, the last menstrual period, number of children born, and determination of pregnancy if any should be asked. Occupational history, you have to ask the age at which the patient has started to do job or work, job set in chronological order, reasons for changes, job satisfaction, ambition, relationships with authority, peers and subordinates, present income, whether the job is appropriate to the educational and family background should be asked. Section and marital history. Section information how acquired and of what kind masturbation, fantasy and activity takes place, if any adolescent sexual activity, premarital or extramarital sexual relationships, if any sexual practices, normal, abnormal, any gender identity disorder, and other areas to be inquired about. Duration of marriage and a relationship, time known, the partner before marriage, marriage arranged by parents with or without consent or by self-choice with or without parental consent, number of marriages, divorces or separations, role in marriage, interpersonal sexual relationships, contraceptive measures, sexual satisfaction, mode and frequency of sexual intercourse, psychosocial dysfunction, if any should be asked, conventionally the details of the family of procreation are recorded here. Premorbid personality. It is important to understand details regarding the personality of the individual, temperament. The age is less than 16 years. Instead of using labels such as schizoid or histrionic, it is more useful to describe the personality in some detail. The following subheadings are often used for a descriptive description of premorbid personality. Interpersonal relationship with family members, friends, and work colleagues, introverted or extroverted, ease of making and maintaining social relationships, use of leisure time, hobbies, interests, intellectual activities, critical faculty or energetic or sedentary, predominant mood, optimistic, pessimistic, stable, prone or anxiety, cheerful or despondent reaction to stressful life events, attitude to self and other, self-confidence level, self-criticism, self-consciousness, self-centered, thoughtful to others, self-appraisal of abilities, achievements, and failures, attitude to work, responsibility, decision-making, acceptance of responsibility, perseverance, foresight. Religious beliefs and moral attitudes, religious beliefs, tolerance of other standards, and beliefs, conscience, altruism. Fantasy, life fiction, non-fiction fantasy, daydreaming, frequency, and content, recurrent or favorite daily. Okay? Habit, food, fat, alcohol, tobacco, drugs, tips. So you have to all ask about everything about sexual relationship with the person, which is also important aspect. Okay, you have to ask about the hobbies, if they're working, how is the work satisfaction, and you have to ask the attitude of the person, whether they're self-confident, criticism, conscious, yeah, self-centered, thoughtful to others, self-appraisal of abilities, achievements, and failures, whether they're optimistic or prone to anxiety, they're cheerful. So ask all these things. What are the hobbies, interpersonal relationships, whether they're introvert, extrovert, how the relations with the family, how's the fantasy, how's the religious beliefs and moral attitudes. One of the most reliable One of the most reliable methods of assessment of a pre-morbid personality is interviewing an informant familiar with the patient prior to the onset of illness. Alcohol and substantial use. Although alcohol and drug history is often elicited as personal history, alcohol and drug can often contribute to causation of several psychiatric symptoms and are other comorbid psychiatric disorders. So, what is physical examination? So, it is a detailed general physical examination duty, systematic evaluation must in every patient. Physical disease is etiologically important for causing psychiatric symptomology or accidental is often detected by good physical examination. Mental status examination. So it's like mental status is a standard format in which the clinician according psychiatric science and symptoms present in the at the time of the interview. MSc should describe all areas of mental functioning. Some areas, however, may deserve more emphatic according to clinical impressions of history. For example, mood and affect in depression, cognitive functions in delirium and dementia. Okay, general appearance and behavior. A rich deal of information can be elicited from examination of general appearance and behavior. For example, it is important to remember patient's social, cultural background and personality. Sometimes some delusions, patients think that they are very rich, dress like that, they have, have money like that. But actually, they're not rich. They're just a psychiatric disorder. They have that they are rich, grandiosity, and someone wants to kill them. General appearance and behavior. You have to see the general appearance, how the attitude towards examiner, they're responding or not, comprehension, gait and posture, the way they walk, the way they're sitting, the motor activity, how they're speaking. Sometimes in personality dissociation disorders, the male patient may take out the voice of a female. That is motor activity you have to see. Social manner, rapport, speed, rate and quantity, volume and tone, flow and rhythm. If you're speaking very fast or very slow or normal. Mood and affect thought. Stream and form content. Okay. Perception, the way they think, the way they think things. Okay. Cognition, higher mental function. Where they, are they conscious? Are they sitting in the OPD doctor? Or the orientation, the day, time, and place? They should know. Attention, whatever questions they're asking, whether they're asking or doing, we should ask. Notice that. Okay, concentration, memory, intelligence, abstract thinking. Inside judgment. Understandably, general appearance and behavior needs to be given more emphasis in the examination of an uncooperative patient. So, if the patient is not cooperating, how to see the general appearance? The important points to be noted are the physique and body habitus, build, the moderate build, very thin or very obese, and physical appearance, approximate height, weight, and appearance. Okay? Look comfortable or not. Okay? Physical health, grooming, hygiene, self-care. Sometimes in some psychiatric disorder, hygiene will be low. So the hygiene issues will be there. The person will not brush, bath, or groom. Okay, dressing, adequate, appropriate, and peculiarity, species, non-verbal expression of mood, and effeminate masculine. Attitude towards examiner, cooperation, guardness, so cooperation, guardness, invasiveness, hostility, combativeness, haughtiness, attentiveness, appears interested or disinterested, apathetic, any integration, the integrating behavior, perplexity, comprehension, intact, impaired, or partially full. Gait and posture, normal or abnormal, way of sitting, standing, walking, lying, motor activity, increased or decreased motor activity, excitement or stupor, abnormal involuntary movements, aims such as tics, tremors, akathisia, restlessness, ill at ease, catatonic signs, Attitude towards the examiner with the cooperative, guardedness, hostility, evasiveness, combativeness, haughtiness, attentiveness, appear of interested or disinterested, attitude, apathetic, any ingratiating behavior, perplexity. Comprehension, intact or impaired posture, fully gait to the way of sitting, any normal or abnormal way of sitting, standing, walking, lying, motor activities, increased, decreased excitement, stupor, abnormal monetary movements, tics, tremors, akathisia, restlessness, catatonic signs, compulsiveness, social withdrawal, autism, grasping, post-grasping, psychological pillow, stupor, ecophrexia, social withdrawal, autism, compulsive acts, ritual or habitual campaign, nail biting, reaction time, social manner and non-verbal behavior, increase, decrease or inappropriate behavior, eye contact, gaze, emotion, staring vacantly, staring at the examiner, hesitant eye contact or normal eye contact, rapport, whether a working and empathetic relationship can be established with the patient should be mentioned. Hallucinatory behavior, smiling or crying without reason, muttering or talking to self, non-social speech, or gesturing in response to auditory or visual hallucination. Yeah. Okay, so hallucinating behavior, smiling or crying without reason, muttering or talking to self or the gesturing in response to auditory visual hallucination. Speech can be examined under the following headings: the rate and quantity of speech, volume, tone, flow, rhythm, yeah, mood, and effect. This is very big. Perception, hallucinations. There should be some examples. Just talking like that is not. Uh, right about mood and affect. Mood is pervasive feeling tone which is sustained, lasts for some length of time and colors. The total experience of the person. Affect, on the other hand, is outward objective expression of the immediate perception experience of emotion at a given time. The assessment of mood includes testing the quality of mood, which is assessed subjectively. How do you feel? Objectively, by examination, the other components are stability of mood over a period of time. So while talking to them, we should ask about volume and tone of speech, flow and rhythm of speech. What are the flight of ideas you see? A smooth or hesitant, blocking, sudden, this prosody, stuttering, stammering, cluttering in accent, circumstantially, tangentiality, verbigration. Thought anhedonia may occur in both schizophrenia and depression. Mood is described as general warmth, euphoria, elation, exaltation, nor ecstatic feeling, severe mania in mania, anxious and restless, and anxiety and depression, sad, irritable, angry, depressed. Okay, despite despite in the depression or shallow, blunted, indifferent, restricted, inappropriate, or labile, liable in schizophrenia. See, what do you tell about thought? Normal thinking is the goal of directed flow of ideas, symbols, and associations. Okay, so characteristics, the rational connections between successive ideas or thoughts. Goal, therefore, thought process that is not goal directed or not logical or does not make sense or realistic. Thought is discussed under the following headings: stream and thought, form of thought. For obvious reasons, the stream of thought overlaps with examination, speech, spontaneity, productivity, flight of ideas, prolixity, poverty of content of speech, continuity of thought is assessed, whether the thought process are relevant to the questions asked, loosening and association, tangibility, circumstantiality, content of thought, any preoccupations, obsessions, recurrent, irrational, intrusive, ego, dystonic. Content of phobias, irrational fears, delusions, false unshakable beliefs or overvalued ideas, explore for delusions, ideas of prosecution, reference, grandeur, love, jealousy, infidelity, guilt, nihilism, poverty, somatic, hypochondriacy, symptoms, illusions of control, thought, insertion, thought withdrawal, and thought broadcasting are Skinnerian first-time symptoms. The presence of neologism should be recorded here. Perception is the process of being aware of sensory experience and being able to recognize it by comparing it with previous experiences. Perception is assessed under the following list. Hallucinations. The presence of hallucination should be noted. Hallucination is a perception experience in the absence of any external stimulus. The hallucination can be auditory, visual, olfactory, gustatory, and tactile. Early hallucinations are common types of hallucinations in non-organic psychiatric disorders. It is really important to clarify whether there are elementary only sounds are heard or complexes of voice. The hallucinations is experienced much like a true perception and it seems to come from an external objective source. For example, from outside the ears in case of an auditory hallucination. The hallucination does not either appear to be a true perception or comes from subjective internal space, for example, inside the person's own head in case of auditory hallucination. These called pseudo hallucinations. Inside the person's own head, then it is called pseudo hallucination. It should be further inquired what was heard, how many voices were heard, which part of the day, male or female, how interpreted, and whether second person or third person hallucination. That is whether the voice is addressing the patient or were discussing him in third person. Also inquire about command hallucinations with the command to the person. And the hallucinations occur during wakefulness or the hypnagogic hypnopompic means hypnagogic means while going to sleep. Hypno hip, hypnagogic when you're going to sleep. Hypnopompic occurring while getting up from sleep. Hallucination, illusions and separation whether visual, auditory or other sensory fields whether occur in clear consciousness or not, whether any steps taken to check the reality of distorted perception. Depersonalization or dereality. Depersonalization and degeneration abnormalities in the perception of a person's reality and often described as if phenomenon. Somatic passivity phenomena is the presence of strange sensation described by the patient as being imposed on the body by some external agency with the patient being a passive receiver. It is one of the Skinner first-time symptoms. Presence of strange sensations described by the patient. Others, otoscopy, abnormal vestibular sensations, sense of presence should be noted here. Cognition, neuropsychiatric assessment of the cognitive higher metaphor is an important part of the MSc, mental assessment or mental examination. Okay, mental system examination. A significant disturbance of cognitive functions commonly points to the presence of an organic psychiatric disorder. It is usually used Holstein mini mental state examination (MMSE). Holstein's mini mental state examination for mental state examinations MSc, MMSc mini mental state examination for systemic Clinical examination of higher mental consciousness. The intensity of stimulation needed to arouse the patient should be indicated to demonstrate the level of alertness. For example, by calling patient's name in a normal voice, calling in a loud voice, light touch on the arm, vigorous shaking in the arm, or painful stimulus. Grade the level of consciousness, conscious or unconscious, confusion, somnolence, clouding, delirium, stupor, coma, Glasgow Coma Scale, where a numeric value is going to be the best response in each of the three categories: eye opening, global motor. Orientation of the patient's well into the time, asking the time, date, day, month, year, session, and time spent in the hospital place. That's by asking the patient present location, building, city, and country. And person test by asking his own name and whether he can identify people around him and their role in that setting. The orientation time usually precedes disorientation in place in person. Attention easily aroused and sustained. Ask the patient to repeat digits forward and backward test. Okay, start with the two-digit numbers. Two-digit numbers. So you have to start with two-digit numbers till failure occurs on three consecutive occasions. So what is this? So higher attention. This attention easily aroused and sustained. Ask the patient to repeat digits forward and backward digit span test. Digit forward and backward test one at a time. So the patient may be able to repeat 5 digits forward and 3 digits backward. Start with two-digit numbers increasing gradually up to the 8-digit numbers until failure occurs on three consecutive occasions. Concentration can the patient concentrate? Is he easily distractible? Asked to subtract serial 7 from 100 minus 7 test or serial 3s and 50. 50 minus 3 test or to count backwards from 20 or enumerate the names of the months. Note down the answers and time to be taken to perform the test. Remember, immediate retention and recall. Use a digit span to assess the immediate memory, digit forwards and digit backwards. So, subtest. Remote memory, intelligence, abstract thinking, break a whole into its part. That's the essentials of a whole. For example, situational concept. We will, end the session here.